what I will be discussing is our issues in hypertension trial. And probably you all are aware of the results of the SPRINT trial that have lowered the blood pressure values. And we know that blood pressure is a continuum. The higher the blood pressure, the higher the risk. The more we reduce the blood pressure, the lower the risk. And we also know that the more we reduce the blood pressure, the greater the reduction in cardiovascular events, most of it coming from stroke and heart failure. But also, if we look at all the different trials, we can clearly see that we have different values of blood pressure thresholds that have shown efficacy. So if we look, we have uncomplicated hypertension. In the elderly, probably we have to be more lenient because it's trials showing that aggressive reduction of blood pressure has basically never demonstrated a clear effect. And the lower you go in elderly, the greater the possibility of side effects. And in diabetes, again, there's probably a value around 130, whilst below probably we don't get a benefit. And in patients with previous cardiovascular events, there's no benefit of reducing it too much. But then we had guidelines that were pretty much in line with each other. There was just a difference in the way we were calling blood pressure, where we were called I normal, and the Americans were calling pre-hypertension. That was just a way of preparing patients to be treated. But until the SPRINT trial was published. And the SPRINT trial was a trial where patients were allocated either to a standard treatment or to an aggressive treatment, and they found that those patients receiving an intensive treatment had a lower blood pressure that was around 120 millimeters of mercury. And that was associated with a significant reduction in events. So it seems pretty clear, large study showing that the more you reduce the blood pressure, the more you reduce the events. The problem is that in these patients there was a reduction in myocardial infarction that was marginal, acute coronary syndromes and strokes, and all of them were pretty marginal, while only the composite endpoint was effective, and there was a significant reduction in heart failure. In heart failure, you know that those patients who are prone to develop heart failure, the lower the blood pressure, the lower the risk of heart failure. But also, these data were a little bit in contrast with data from previous studies. We had a study in diabetes that was the ACCORD study, where that was more a program where they looked at the effect of intensive glucose lowering, the effect of intensive lipid lowering, and intensive blood pressure lowering. And the ACCORD study showed that reducing blood pressure to 120 millimeters of mercury was associated just with a marginal effect on the primary outcome, and was mainly because of an effect on stroke. Whilst the effect on related to the side effects related to hypotension were outweighing the risks. So basically we had trials over the years that have shown efficacy of blood pressure reduction up to a value of 130 millimeters of mercury. Then we have two discordant results, the ACCORD on one side and the SPRINT on the other side, with the ACCORD showing that basically there was no benefit, and SPRINT showing that there was a benefit. So where is the truth? Both of them were randomized clinical trials, and the SPRINT also showed that there was a significant risk in patients treated aggressively of hypotension, acute kidney injury, and hyponatremia. The main issue was the way they measured blood pressure in the different trials. So if you look at the way, it's often when you conduct a trial for blood pressure, you give a treatment, then patient come, you wait for 5 minutes, and then you have the blood pressure measured. That was different in SPRINT. In SPRINT, patients came in, they were put in a separate room, and they measured by themselves the blood pressure with an automated measure. So that per se was a different way of measuring blood pressure, because that was more similar to what we call home blood pressure rather than the clinical blood pressure, where there was no effect of the nurse, the technician, of the doctor in measuring blood pressure. And we already knew that there was a difference between the clinical, the ambulatory, and the home-based blood pressure, and the different interaction between the physician, the nurse, technician with the measurement is associated with higher blood pressure levels. And we know that also there's a difference between the automated and manual blood pressure, which is a difference of 15 millimeters of mercury for the systolic and 8 millimeters of mercury for the diastolic. So basically, if you think of the blood pressure values achieved with Sprint, there was when they were around 120, basically they are in line with what we think are the different measurements, because basically the 120 was probably similar to the 140 that we were obtaining. And the fact that the blood pressure measurement is important in determining the value that you get was already known since long time. And this is a very early study from the 80s by a group from Mancha that showed that the effect of doctor walking into the room on blood pressure. You see that this was the blood pressure when the doctor walked in the room, and this was the blood pressure when the doctor left the room. So just the effect of walking into the room had an effect. And so the home blood pressure has significantly lower values compared to the clinic blood pressure. So at the end, the message here is not the different target that was important, was the measurement. And so measurement is important. And when you conduct a trial, whenever you will design a study, it's important that you always validate your method, and that your method, and then you know what is the variability between methods, because then you may get to wrong conclusion, because the Sprint has led the American physicians to lower the targets of blood pressure. So we have more patients who are treated more aggressively, and possibly they get more side effects because of lowering blood pressure, because of the misunderstanding of the results that were obtained with a measurement that per se leads to lower blood pressure levels. Now, the other problem in designing clinical trials in hypertension is related to the fact that usually we need a mean of 3.2 drugs in order to control blood pressure in our patients. So it's not just one tablet. There are very few patients who are lucky that they are controlled with one tablet. The majority are controlled with at least three tablets. And combination therapy is more effective than increasing the dose of a drug. So if you give a drug A and then you give a certain dose and then you increase the dose, the effect is much less if you use drug A at lower dose plus the lower dose of drug B. So combination therapy is more effective. And this has important implications in the drug development, because now combination therapy is also suggested as starting therapy. And therefore, if we want to develop any new drug, we have to see, yes, if it has an effect on blood pressure per se, but also what is the strategy of combination. And this is, for example, one of the first studies that was conducted with testing at different strategies of lowering blood pressure. This was the ACCOMPLISH study, where they used benazepril plus amlodipine, or benazepril and hydrochlorothiazide. And basically, they showed that the ACE inhibitor plus a calcium channel blocker strategy was better than an ACE inhibitor plus a loop diuretic in reducing blood pressure. And therefore, it is important for the future to understand how best develop these drugs. And if we look at the studies that are required for the approval of new drugs, you see clearly that at the moment the regulatory agencies ask for studies against placebo or studies versus a comparator, but unless you suggest a new fixed dose combination, they're not asking to prove the efficacy on top of another drug. Now, I'll show you one of the studies that have been conducted with one of the new antihypertensive medications, that is the last antihypertensive medications that have been approved, and that was aliskiren. Aliskiren is a renin inhibitor, and in this study, basically, they tested in a parallel group the placebo and aliskiren. Also, they tested the comparative effect of aliskiren with hydrochlorothiazide and the association of aliskiren hydrochlorothiazide versus the single drugs. So you see that you can design trials to show the efficacy against placebo, in this case, the efficacy against a comparator, and the additive effect of the two drugs given together. And basically, it was an effective antihypertensive, but because of the several other issues, has not really made it into the market. So the challenges we have now in hypertension is define the measurement standards, and whether we're going for home blood pressure, and we have now devices that can measure exactly blood pressure, record time, and record number of measurements, or we go for unattended measurement, was what the Sprint was as adopted, or we go for clinical blood pressure. It doesn't matter. What it matters is that we have clear standards, and we have a clear correspondence, and we understand that the 120 measured at home is equal to 130, 140 measured in the clinic, and so that won't affect the guidelines and the practice. Because the message that came out after Sprint was, yes, it is effective to reduce blood pressure, and you have to reduce blood pressure below, up to 120 millimeters of mercury. That is not exactly what the Sprint study has done. At least when I get patients into my clinic, I mean, they go to the nurse takes the blood pressure, and then they come to see me, and that value of blood pressure is very far from the one that they could measure if we lock them, we put them into a room, and we have the blood pressure measured by themselves after 5 minutes. So it is important that we are clear on the measurement standards. The other point is the effect of the endpoints. It is important to look at the endpoints. Probably mortality is important, stroke is important. It is important also to look at the safety, because it's if a drug is effective in reducing events in one side, but then increases the offset risks on the other side, say a need for emergency dialysis or worsening of renal function, then the benefits and the risks should be balanced. The other point is also the compliance, because patients that are now taking fixed dose combination tend to be more compliant because they take less tablets, and it's easier to remember to take one tablet rather than to take 3 or 4 tablets. So dual or triple combination are important, and the importance of compliance on the efficacy is also important, and therefore the combination therapy. As you can see, there are several aspects that are important, and if in the future you will be designing a clinical trial in hypertension, it's important to take all of this into account in order to conduct the trial that then has an applicability to clinical practice.